Co-leadership, and this is sort of extending Jody Gittle's work. We asked all the respondents to tell us how much they felt physicians or nurses took the lead in various decisions within the unit. Okay? So a nurse can tell us about physicians and nurses, they're the same thing. These measures really worked neat. In a rotated factor analysis, the physician leadership measures loaded completely separately than the nurse leadership measures. They were clearly distinct measures. Okay? The Cronbach's alpha on reliability was pretty darn good. And the correlation between the two of them was 0.5. And I'm going to show you a little graph here. What you can see there is it's not at all, when you tend to have strong physician leadership, you tend modestly to have strong nurse leadership, but there's a number of facilities here that have strong physician or low physician leadership, strong nurse leadership, and vice versa. So we got quite a range of variation on that. Our results, and I'm going to come back to the personalities and rewards and leadership, because it's sort of a real interesting interaction effect. What we find here is that, first of all, co-leadership by physicians and co-leadership by nurses both cause interdependence. And if you want to ask me how I did the instrumental variable regression and the causal analysis, I'll tell you, but I will use the term cause. Second, greater the interdependence, the greater the psychological safety, and the less the difficulty in coordinating HF care, which is what we hypothesized. Third, the less the difficulty in coordinating HF care, the greater that providers felt that they were prepared for providing individualized care. Preparedness for providing individualized care led to greater satisfaction with heart failure care. Here's the one that people like nowadays, is being prepared for providing heart failure care, providing individualized care, and participation in QI activities, decreased 30-day admission with a primary HF diagnosis. Okay? And I used a joint test here. What happened is participation in QI activities leads to prepared for individualized activity, as does low difficulty in coordinating. And so so there's an indirect path there. The joint test is significant. If you take participation in QI activities out of the model, preparedness for providing individualized care is significant at the 0.05 level. So I think we have pretty good effects there. I want to talk about what causes heart failure leadership. Now this is sort of interesting. The red line is the line for high connecting personalities. We have facilities with high connecting personalities. The blue line there is for low connecting. And what you see for both nurses and physicians, if you have a low emphasis on heart failure care and low connecting personalities, you get leadership in both nurses and physicians. You get slightly more leadership if you have high rewards and high connecting personalities. Where you don't want to be is putting high rewards into a situation of people that you have low connecting personalities, because you're going to get very dismal leadership out of it. And the way I'm interpreting it is that low rewards mean that there's not much joint pressure for getting something done, so that allows people who are independent, who want to work separately, to emerge as leaders by themselves. Put in the high rewards, and that puts a little bit of pressure on them. And then you need the connecting personalities to put it together. The other thing that we found is really neat is for nurse leadership, a supportive facility context is really important. Okay, so in other words, the facility opening the door, providing a context to allow nurses to be leaders, to support them in being leaders, is something that was also a cause of nurse leadership. We did a subset analysis, so we'd ask all the respondents whether or not their facility had a care group. These care groups are predominantly from the facilities that have a heart failure clinic. They are larger stations. They had a higher participation rate in quality improvement activities. They were more likely to see themselves as being rewarded strongly for heart failure care. It looked like these were teams. Did fairly well on the readmission rate, a 1-unit increase in these units for prepared for individualized care. And that's about a 1 1/4 standard deviation increase in prepared. Led to 85% of the for readmissions for heart failure as a primary diagnosis, about 86% for heart failure primary or secondary, or 86% for any diagnosis. So in other words, and they're all significant. Okay. And they're significant when I do the instrumental variable approach. So I think we have a pretty good story there. I'll toss it over to Joanne there.
So what does this mean? Well, the thing that was exciting to us, and the reason why we wanted to look at context, is we wanted to identify some actionable steps. A lot of the work has been done in trying to get people to value or to be more of a connecting personality, and that's just not going to be fruitful. So what are the things that we can put in place from the organizational standpoint in terms of the expectations, in terms of the goals, the rewards, the incentives, the orientation, the creation of these interdependencies? So how do we work on that? And so that as we looked at the CHF care, it's more than just the routines and the processes. It also involves, so I think this afternoon's session, the similarities are the interplay between not just the individual, but the context, the processes, and also effective teamwork. And teamwork not just in the sense of everybody liking each other, but that knowledge of we do have different bodies of knowledge, we do have maybe different points that we can enter the equation. The whole concept that Eduardo Salas would talk about is not just teams of experts, but expert teams. And I think that's a very powerful mental model for me, because what we often think is we've achieved what we want when we bring together the experts, but there's no horizontal integration. And that's partly what we're seeing that the relational co-leadership should be helping, is that we're not just skip education, we're not just in parallel play in the clinical setting, that there is an appreciation, an understanding, a reliance. It does allow also for the shift that in this context, I would have the expertise. In that context, you would have the expertise. So it opens some different thinking about the processes, the policies, the fact that the organizational infrastructure can really help make the right way work and the wrong way not as effective. Is there the evidence that the relations are causal? And this is some of the work that we want to, are they relational, are they causal, that we want to pursue? And then what should we be doing? Well, what can we do to increase interdependencies that are not solely related on the fact that we like each other? It's got to be organizationally driven. It's got to be clear expectations. The idea of how are we oriented and how are we educated in the clinical setting, a number of those kinds of ideas and strategies. Again, when I was a nursing administrator and working with my physician counterparts, we were able to come up with things that were complementary to the people who were part of the care process. And so it gives us some actionable items, we think, as opposed to encouraging people to function like a team or encouraging people to value the contributions of others. And then how does interdependence work? And Doug alluded to some of the ideas that we have, but we want to carry this further. How can we promote leadership to increase it? And then I want to take the last minute to talk a little bit about where we go from here. In addition to many of you, we are working on our manuscripts. We've got 3 identified that we've started on. Doug presented this information Monday, this past week, in Palo Alto at the CHF query to the cardiologists and to a number of the other healthcare providers that are taking care of CHF patients in the VA system. And so we plan to continue working with them to explore our next level, which would be to take a look at what might be a design or an intervention bundle, and how would we take the findings from this study and begin to apply this to a broader, as an intervention to the CHF query. We have also gotten a grant from the university, from the Center for Integrative Leadership at the University of Minnesota, to take what we have found at this point and go to 4 different care teams. And this would be either 3 or 4 members of a care team, self-identified, some with CHF and some not CHF, to have them react to our model, react to our findings. This idea of interdependency and the power of this relational co-leadership concept, does this ring true? So we're in the process now of validating and getting the input, doing some reflective, asking them to react to what we found, and does it ring true in terms of a validity? So we're in the process of that. But I think the key thing, and probably the bottom line action item that we are wanting to do, is to really take a look at how do we define this relational co-leadership. As I mentioned, we see it as based on Jody Gittell's work, and how do we take this to the next step in terms of defining it, measuring it, recognizing when it's there, and then seeing the impact on outcomes. We are done. Thank you so much.